Welcome to our ATS Thoracic Oncology Assembly webinar, Components Necessary for High-Quality Lung Cancer Screening. My name is Stella Ogake. I'm an Assistant Professor of Clinical Medicine at The Ohio State University, and I'm joined today by Roger Kim. He's the Chair of the ATS Thoracic Oncology Assembly Early Career Professionals Working Group, and he's also an Assistant Professor of Medicine at the University of Pennsylvania. We will be co-moderating today's discussion. Before we get started, we just wanted to remind everyone that this live event will be recorded and uploaded to the Thoracic Oncology Assembly website and YouTube page afterward. If you have any questions throughout the webinar, please place them in the chat or in the Q&A, and we'll try to address as many of those at the end of our time together today. As a reminder, the views expressed during this webinar are those of the speakers alone and not necessarily endorsed by the ATS. With that being said, I'm very excited to introduce our lung cancer screening expert panelists who recently co-authored the article published in CHEST last month, which was the Lung Cancer Awareness Month. The title of their article is Components Necessary for High-Quality Lung Cancer Screening, a 10-year update. They represent some of the world's preeminent leaders in lung cancer screening, and we're honored that they've agreed to participate in this webinar today. So first, Dr. Julie Barta is the manuscript's lead author. She's the current chair of the ATS TOA Program Committee, an associate professor of medicine, and the lead for the Common Respiratory Institute's Lung Cancer Screening and Nodules Program at the Jefferson Medical College of Thomas Jefferson University. Welcome, Dr. Barta. Next is Dr. Douglas Arenberg. He is the recipient of the 2025 ATS TOA Enduring Impact Award and a professor of medicine in the Division of Pulmonary and Critical Care Medicine at the University of Michigan. Welcome, Dr. Arenberg.
Thank you.
And lastly, Dr. Peter Mazzone is editor-in-chief of the journal CHEST and the director of the Lung Cancer Program and Lung Cancer Screening Program at the Cleveland Clinic Respiratory Institute. Welcome, Dr. Mazzone.
Thanks for having me.
Before we dive into our discussion topics, Roger will provide a brief high-level overview of what's covered in the recently published CHEST article on the components necessary for high-quality lung cancer screening. Take it away, Roger.
All right, thank you so much, Stella. So I'm just going to provide a quick high-level overview of what this excellent article covered, which, as Stella mentioned, is components necessary for high-quality lung cancer screening. And this is a 10-year update from a previous article that had initially introduced this topic. And so just to cut to the chase, the 8 components that were recommended in this article were: number 1, lung cancer screening target population; number 2, lung cancer screening uptake and adherence; number 3, shared decision-making, including tobacco treatment; number 4, performing low-dose CT imaging; number 5, identify and report low-dose CT imaging detected lung nodules; 6, managing screen-detected lung nodules; 7, reporting and evaluating non-nodule low-dose CT imaging findings; and then quality improvement measures. Just because of in the interest of time, we are going to be focusing on these 5 of the topics, just because we think that there's probably the most to dive into within these specific components. And so briefly, I'm just going to take us through each of these 5. So the first component, lung cancer screening target population, and these are just pulled from the article that we're referencing, really highlights that the importance of defining the actual target screening population, recognizing that the USPSTF 2021 guidelines are just one of several different proposed guidelines that are summarized here in this table, at least with the United States, and then even additional ones that have been recommended internationally. And we'll get into some more of this in our discussion. Component number 2 is lung cancer screening uptake and adherence. And really, this is encouraging programs to develop strategies to increase both uptake and adherence that is appropriate, including appropriate follow-up for individuals, including individuals in underserved populations, in order to maximize the net benefit of screening. And they provide some targeted strategies by which to do this, including leveraging the electronic health record, enhancing community outreach, engaging our primary care colleagues, and then improving education for patients, and also using patient navigators. Component 3, shared decision-making, including tobacco treatment, is also recommended within this article. And there are a number of very specific options for partaking in shared decision-making that programs could potentially utilize as well. And then components 6 and 8, manage screen-detected nodules and quality improvement measures, are highlighted in this article and really focus more on, how can we follow guidelines or at least come up with program-specific strategies for managing the higher risk nodules for component 6, and then putting forth specific quality improvement measures. And I should mention there are a couple different articles that some of the panelists on this webinar have authored that delve more into these specific quality improvement measures. But with that being said, I'm going to go ahead and stop sharing my screen, and we're going to start diving into some discussion questions. And so first, to kind of kick off the discussion here, I'd like to start off by asking a question about the first component for which discussing the lung cancer screening target population. And as highlighted in the manuscript, there currently exists several distinct screening guidelines endorsed by a variety of different organizations and countries around the world. And for practical reasons, many U.S. screening programs currently have chosen to adopt the 2021 USPSTF guidelines, as they are largely in line with CMS reimbursement policies. In the absence of universal consensus, however, regarding eligibility criteria and limitations of insurance coverage for those interested in lung cancer screening outside of the guidelines, how do you think programs should determine who to screen? And for this question, we'll start off the discussion with Dr. Barta.
Thanks, Roger, and thanks for inviting me here today to chat with everyone. I think in how we frame component 1, the biggest sort of underscoring factor is consistency. We feel that it's important that programs define and are clear in their definition of who is the target population that's at risk. And different programs, depending on the region of the world that they're in, the resources that they have, et cetera, may feel that the target population might be different. But being consistent in determining that high risk status and following the guidelines that are available, the data that support benefits over harms for screening is what's really important for component 1.
Dr. Mazzone, Dr. Arenberg, please feel free to jump in and provide your thoughts as well.
I think this is one of the most fun aspects of lung cancer screening to talk about, and as if an academic-minded person who spends a lot of time in this, there's really so much richness to the literature and the ways of thinking about who we should screen. At the same time, it's also probably the most practical of all of the components. Practically speaking, if you're starting a program, or if you're at all resource constrained, if you're worried about, you have great guidance about who you should be screening. And that's provided by Medicare and the United States Preventive Services Task Force. That's who is covered for screening. And so the simplest answer is screen within the populations that are covered. Most programs have a lot of those individuals who meet that target population that are yet to be screened, a lot of opportunity to grow. And as you're doing so, as you're developing, a systematic approach to your screening, then starting to dive into some of these other groups that aren't just at risk, but that you think could have a net benefit from screening, so more benefit than harms, which ties into, but is not analogous to their risk, I think, gets fun. Most of the stakeholder societies that have added groups that are shown in this article, they want more people to be screened. They want more cancers to be screen detected. And so they start extending out these categories based on, evidence in groups that weren't really included in the randomized controlled trials. And oftentimes those are based only on, hey, I can identify someone at risk. where you need to be a little careful is at risk of getting a lung cancer isn't the same as being at risk of dying from lung cancer or being able to benefit from early detection of lung cancer. So some of these other criteria can lead you to screen individuals who may not have quite the same net benefit as those who are currently covered. So a very fun question we could probably talk the whole hour about. If you're new to screening, hey, stick with who's covered. That's plenty right now. And then as your program grows and matures and you can handle a large number of people and safely evaluate all the nodules and things you're finding, considering groups outside of those standard ones who still might have a net benefit would be very reasonable.
Yeah, I won't add too much to what Peter has said. There's the constraints of who will be covered, by insurance, and that really is through the Affordable Care Act. Anybody who's got a grade A or B recommendation from USPSTF should, those should be covered. That is, I feel like we're at the same time we're learning to walk, we are trying to run, and some places like I think can do that very well. When you start applying some of these more complex models of life years gained or risk models, you run the risk of taking it out of the hands of the people who really are at the front lines, which are our primary care doctors. We're asking them to do a lot. And so I'm always mindful of the fact that while I'm like Peter, I'm very excited about these models and what they tell us and how we might be able to really zero in on people who have greater net benefit. I also recognize the constraints of the system that we work in. And I think that focusing on the simplest criteria that we can and making sure that our primary care colleagues are comfortable with that. And if you work in a centralized screening program, then perhaps it gets easier to implement some of these more highly nuanced models that point us in the direction of people with the greatest potential benefit. But I think in a system where you don't have that centralization, learning to walk before you can run is simple, and that's age impact your criteria, in my opinion.
I think the other interesting aspect is, understanding the analyses at the population level, and then thinking also about individual patients who are sitting right in front of you in the exam room, right? Because we all have had patients come to us who are maybe USPSTF ineligible, but have other risk factors and have a really high concern about their lung cancer risk. And so I think learning how to talk through, that tension between population level harms and benefits and then, individual level priorities as well is also a really interesting piece of determining who can be screened for lung cancer. Of course, for different criteria, right? We have different levels of evidence. I mean, for some alternative criteria, we have some modeling data that suggests that there may be some net benefit for individuals at high risk, but not meeting USPSTF criteria. Whereas for other alternative criteria, for example, duration of smoking, we have less evidence. So I think there's a lot to learn in this area that hopefully will shape how we're defining the target population.
I think one of the harder things in this, I shouldn't say there's so much that is hard, but is, who shouldn't we screen? Who in these populations even might be too sick with comorbidities or limited life expectancy to truly benefit? And there again, as Julie points out, you get into this tough situation where, a population level lack of net benefit, how's that translate into that individual in front of you? But I know my own program, we struggle with that. We get referred.
We're good at predicting mortality with populations. We're terrible with people. And I want to put Peter and Julie on the spot. So you got someone who's not eligible, but really wants to get screened. How do you practically handle that?
It's easy for me because it's really my team members that are seeing these people and doing the shared decision making. It's the nurse practitioners and physician assistants. It's so easy for me to say, just don't, when somebody comes in and they're in a wheelchair or using supplemental oxygen, they're probably not going to benefit.
Right.
But all I ask really is that they have as good a discussion about the potential benefits and harms, what you're going to find. And, it's where, and I'm sure we'll get to it at some point, but it's where the nuance and difficulties with a good shared decision-making visit come up. How do you speak to someone at one spectrum of the benefit harm and another and all those in the middle? So here, I didn't answer you so directly, but I'd encourage my team not to screen somebody who's using supplemental oxygen, who is, not able to walk a reasonable distance. And on the front lines, I recognize that they may not always be able to follow that.
Yeah, for us, when patients are referred to our centralized program, our nurse navigators call to confirm screening eligibility, and those who are ineligible, just get a brief discussion over the phone for the reasons that they're not, and then a note back to their primary care doctor just explaining that they're ineligible, usually due to their smoking history or low intensity smoking or quit years. But sometimes, some patients will express a really high level of concern. So our navigators will set up an appointment with me. And so depending on, I think, patients' sort of understanding and what the questions that they have, some have done a lot of background reading and are actually really, have an in-depth understanding of how lung cancer screening works. And then others just have may bring a different perspective, to their level of concern. And so I try to meet them where they are, and go through what we do know and what the data show. And then, I guess it's just another form of shared decision making. Of course, if anybody has symptoms or, any other clinical reason to get a scan, then, we'll do a diagnostic CT. But sometimes, there are risk factors, including family history and other things that, after having that discussion, on a case by case basis, sometimes we proceed.
And it's not uncommon that somebody with that many comorbidities to maybe limit life expectancy have already had a CT scan in the last year or two as well that you can point to be honest.
All right, thank you all so much. Let's move on to component number 2, which is lung cancer screening uptake and adherence. So in table 2 of the manuscript, several specific proposed strategies for increasing screening uptake and adherence are proposed, including EHR-based interventions, community outreach, PCP engagement, patient education, and patient navigation. However, all of these interventions require significant resources, time, and personnel to establish and maintain quality and effectiveness, especially as volumes hopefully continue to increase with increased uptake of lung cancer screening. So which of these strategies do you think programs should begin with or prioritize to improve uptake and adherence? And for this question, we're going to start with Peter.
I think it's a great question. There's a ton of gaps in care and getting people in and getting people to come back, are two of them. I don't think that there's just one solution, one home run to wipe out all those gaps. And so you have to take kind of small or measured victories with individual projects and approaches to this. I think the way we've framed this and the way you're asking it is already assuming that this is a program. This is a screening program. You're educating the providers who will be referring patients into that program or ultimately performing some of the tasks within screening. And so I'd encourage everybody to consider their lung cancer screening situation to be a program, as opposed to just, okay, we're now offering screening and individuals can go out and hopefully remember to get a low-dose CT scan for their patients. The first step, I think, is awareness. And so the education piece is inexpensive. It's just the program leader's time to go out, educate primary care, where a lot of the patients will come from. And so you're not asking for a ton of resources other than maybe a little bit of your time for that. Each health system, each outpatient center or hospital probably has their own communication tools. Maybe it's medical grand rounds, maybe there's quality meetings, maybe they have newsletters. My experience suggests you need to use as many or all of them as you can and repeat them over time, because everyone doesn't always hear or remember them the first time. And once that's in place, making ordering as easy as possible with the EHR, making communication as seamless as possible with return of results and follow-up. Then I think you're still going to notice gaps that you have to be very creative about. The fact that they take time and resources, I think, should never be an excuse not to address them. You may be told no 5 times, but the 6th time, you get to do something. It's just the way things are. I'd always come with a good, well fleshed out idea. What sort of uptake might that increase, and what are the implications for the health system, whether they're financial or community based, that you can use to support your requests. Also, I think if you just ask for a ton of people to address every issue, you may get turned away. You kind of have to show some success and that you're strained or stressed. But look for tools that can be built to automate things. The EHR reminders, the EHR outreach tools. They sometimes take resources up front, but then they live on without a whole lot of additional resources needed. Nowadays, with all of the automation and advances in AI and things of that nature, there should be ways to address uptake and adherence that don't always require hiring new people or taking a whole lot of people's time. So I think a thoughtful approach, starting with education, but then building from there is a good way to do it.
Yeah, I agree with that. I think that definitely understanding the resources that are available to you and maybe the strengths that your institution has is really important, because every site and every health system is going to be a little bit different, and even sites within a single health system can be different from each other. And so there may be places where, there's a very strong primary care network, and engaging with them might get you a lot further, in terms of, lung cancer screening, sort of awareness, and uptake, compared with other places where maybe directly connecting with patients, if there's a very, robust community outreach and engagement program that's already in place from the institution, right? You can leverage those types of things. So doing a little bit of homework to find out what resources are in place, what, foundations are already built that you can sort of stand upon to grow lung cancer screening is key. And that, again, could be different, again, in different hospitals within a single health system.
Yeah, I think it may have been 20 years or so ago that I first kind of went down the rabbit hole with Peter and a project to identify quality measures of something related to lung cancer. And what I've learned about quality improvement is it's like politics. All politics is local, and all quality improvement is local. And Peter and Julie have really nicely identified that every single health system out there has its own unique strengths, but also barriers. And I've been at Michigan for 35 years, and so it's very easy to get a little tunnel vision and not realize both what we do well and the things that we need to do better. And so in our program, it's been a matter of both struggling to get resources, which we're getting slowly but surely, but also then recognizing areas where we just could very simply leverage something we already do well and have a big impact on our program. I think it's understanding, it's like, the golf analogy, you play the same golf course over again, which sand traps to avoid. So I would say know your traps, take a step back and objectively evaluate where you are. And that table 2 in the paper we're discussing is really an excellent list of places to start looking. It's by no means exhaustive, but I even learned some things about my own screening program from looking at it through this lens.
I think the one other thing you didn't mention is it's really helpful up front to be collecting data about your program when you're going to make these. Please, are your providers' slots entirely full. You need more space to grow. What's the downstream consequences of your scanning? How many biopsies, how many surgeries, how much therapy, what does it mean? How many smoking cessation consults are placed and those sorts of things. What is your outreach? What is your uptake, compared to the number of cancers diagnosed in individuals who are screen eligible? How many are coming through your program? So how much more growth opportunity might there be? Having all this data at hand when you design an approach to increase uptake that might require some resources is very helpful.
Thank you all for sharing those excellent insights. Certainly, I think a lot of work needs to be done, and 100% agree with Dr. Arenberg's comment about quality improvement being a local issue, as I think among a lot of our casual, curbside discussions with colleagues, we all know that each of our different institutions has very specific different barriers to overcome, I think, to make sure that we're doing best for our patients for lung cancer screening. I'd like to shift our discussion now to something that we already alluded to during our first discussion. That's bringing us into component 3, which is shared decision making, which also includes tobacco treatment, as mentioned in the manuscript. And I think before we even dive into more of the finer details, I'm wondering if I could get everyone's thoughts on the fact that several publications have demonstrated that there is actually significant variability in how shared decision-making is delivered in clinical practice, including how programs determine what even constitutes shared decision-making. I think this has been an ongoing debate over the past, over 10 years since lung cancer screening was first given a USPSTF approval. But I'm curious what all of our panelists think comprises the minimum standard required for effective lung cancer screening shared decision-making in real-world clinical practice, and also how you think this should best be implemented. And for this question, we'll start with Dr. Arenberg.
Yeah, so it's interesting so what is the bare minimum? I think it's easier to identify what not to do, but I'll try to do both. What not to do is to see a patient who's used tobacco in the past all of a sudden have new pulmonary symptoms and say, oh gosh, you have these new symptoms that we need to think about and you've used tobacco. That is not the time to do lung cancer screening. When someone comes to your clinic with new symptoms, that's the time to do a diagnostic evaluation, which may or may not include imaging. But there is a big, big difference between ordering a diagnostic CT and a lung cancer screening CT. And I do want people to think about that. But backing up to the whole shared decision-making concept, this is something I became interested in. And we developed a tool to help people do it. But really, I think the tool for me is more of a framework for thinking about what do my patients need to know. The first thing I try to do is make sure patients understand that it's part of a larger public health initiative is all cancer screening. Colon cancer, breast cancer, cervical cancer, and now lung cancer screening. And so in that context, it takes some of the stigma away, because I think we are dealing with an added layer of stigma when it comes to people who are eligible for lung cancer screening. I let them know that this is part of their routine preventive care. So I think we should let them know that. And I think that they should understand, just like any other test, that there's false positives and that they should have a pretty good understanding of what to expect from the test. So I think if you're a primary care physician out there wanting to do the bare minimum, I think I would try to first destigmatize lung cancer screening by indicating that it's part of your routine clinical care, and that because of your prior history of tobacco use, we think you might benefit if you're otherwise healthy from this CT scan, which is not a single test. It's a process, and it should be done annually. I think that needs to be included in there. I see too many people, and we'll get to this issue about adherence to follow-up, but I think that's, if I had one magic wand to wave, it would be getting people who get their initial screen to come back for their subsequent screen. So I want people to understand that screening is a process. It's very, very valuable for people who are otherwise healthy and at risk for lung cancer, but it's not something that they should have their arm twisted to do. And I think those are the kind of the bare minimum components. that took us, 2 minutes to do, right? But I think a real shared decision-making conversation probably with most patients is going to take 5 minutes of a visit that may only have 7 or 10 minutes of face-to-face time available to them. So we have to recognize our primary care partners are burdened, and that's why I think some component of a centralized shared decision-making process is probably the ultimate best way to do this.
Yeah, I agree.
You go ahead, Julie.
I think framing, the screening as part of, routine cancer screening like we do for everything else. That's how I start. I don't do my own shared decision making. I usually just refer if I have patients who, have not had a CT in the past 12 months and are eligible, I refer to our screening program. But as a way of introducing the topic, that's actually the exact first thing I start with, is just like we get mammograms every year for breast cancer screening and colonoscopies. This is to screen your lungs. And so, yeah, the stigma piece is such a huge part of overcoming a big barrier for many patients. I think the other really critical component of shared decision making is the tobacco dependence treatment for individuals who are currently smoking. And here, we don't know yet what are the best and most effective strategies for integrating, tobacco dependence treatment into the lung cancer screening context. I think for all of us, it intuitively makes sense that this is the time that we want to spend and talk about it with patients. But we've seen many, randomized controlled trials in this space that have not really defined a clear best strategy for delivering tobacco use treatment. It's probably, something that is very intensive with lots of, patient touches over time, which again can be resource intensive. But, no matter how we do it and no matter what the resources are, that has to absolutely be a part of that shared decision-making conversation. Whether it's, something very brief and some info, like a pamphlet handed to the patient versus counseling that is tailored to where that patient is at in their journey to quit smoking. Anything I think on that gamut is important to include.
Yeah, I agree with everything that was said. Often, tied to the stigma conversation is nihilism, that there's still a lot of doubt in our patients that we can do anything about lung cancer. And so I think that shared decision-making should highlight how much additional benefit there is to finding lung cancer early. Most people, I think, are unaware of how high the cure rates are when it's found early. You see people who are eligible for lung cancer screening and not coming are often up to date with their other screenings. So it's not that they are against screening.
Yeah.
They just somehow are, making decisions differently about lung cancer than breast or colon.
Or just how much misconception there is about what it is to have surgical removal of lung cancer. Most patients have this horrifying image of a thoracotomy, which even most thoracic surgeons would say, that is horrifying compared to what they do. And we've got so many touch points where we can take away some of the assumptions that are built into patients. You can see it sometimes in their face. They harden when you begin to talk about it. And, you can also see it soften a bit when they get the real truth about what, the way we treat cancer and the options that are available for it. And it's such a fast moving field. There's so many things to be excited about. And we lose sight of the fact that maybe our patients aren't aware of that.
And the two other Doug had mentioned, making sure they're aware that screening's annual. The other is preparation for the results.
Yeah.
Almost always there's a nodule, and we don't want to scare anybody, and make sure they're aware that they're usually benign, and we'll walk them through it. The final one I'd say, and it's maybe somewhat unique to very structured programs where people come in for their shared decision making, is I've always seen it as a great opportunity to build a relationship with that patient. If you're not their primary care doc and you're walking them through this, engaging with that person, building that relationship is going to help them come back, might help them listen to you when you provide tobacco cessation guidance, when you have to tell them about a result that they need to follow up on. So I think that's a a very critical component of a shared decision-making visit. There was a recent paper that looked at SEER Medicare and looked to see, is there a difference in adherence if you did get billed for a shared decision-making visit? And a couple of the points. One is, yes, there was. You were more likely to be adherent if you had shared decision-making. The other point was it only was billed 11% of the time. So there's still not a tremendous amount of shared decision-making occurring.
Yeah, and I think in the paper that you're referring to, Peter, and I think it was by Lisa Carter-Bawa and her colleagues, they measured through a survey study the quality of shared decision making. So I think Roger and Doug, you mentioned that just a couple minutes ago, that how do we measure patient understanding and quality of the discussion? The survey study that was completed included, decisional conflict scales, and willingness to screen, and then looked at screening completion as well, I believe. But how do we identify, like, what's the best way to deliver this? I think, we don't ideally know yet. And I think it differs for every patient, I have to say. From what I hear, from our screening team, that conversation, the basics are all the same, but it's tailored a little bit depending on where patients, are responding to.
Right. Thank you so much for that those insights. I would like us to now move on to managing screen detected lung nodules. And the question that I have for you is about the recommendation that a structured guideline-based approach to be used for low-risk nodules. We know that overall, clinicians don't really adhere to clinical guidelines that have been put out there for managing nodules. And usually they will deviate from guidelines from a ton of publications that have been published about this. So what strategies do you think could most effectively promote guideline concordant care? Or alternatively, do you think that clinical guidelines need to be revised?
So for lung cancer screening, management of the nodules detected on screening, right, we use almost universally the ACR lung RADS categories, which I think provides a really great structured, sort of standardized basis, for all of us. And I also feel like it is a little bit more structured than, for example, the Fleishner Society guidelines for incidental lung nodules. The definition of high risk, right, is obviously very clear. And then the follow-up timeframes are a little bit more structured. So I think that in itself is a good starting place. However, we all know that there is not robust evidence for determining the follow-up timeframe for lung nodules, whether they're incidental or screen detected. So certainly with the more complex nodules like lung RADS 4B, 4X, right, that's where the multidisciplinary discussion comes in. And, that was actually included in the original 2015 iteration of the high quality components, as being a really critical part of lung cancer screening, to have multidisciplinary support and steering committee, et cetera. In this version, I think that multi-D theme really runs through the entire 8 components, because different team members, right, working together need to address all 8 components across the entire spectrum of lung cancer screening. So that's also a really essential area to make sure that we are thinking collaboratively, making sure that we use the evidence that is available for nodule management, and for those really complex nodules, engaging early on with other subspecialties that have additional expertise.
Yeah, I think, when you're developing or even looking to improve your screening program, you have to have high quality lung nodule management. There's no, once you get someone in and they're coming back, they're uptake and adherence. I mean, so much of the balance of benefits and harms is related to lung nodule management. And that's excellence in radiology reporting, reading, and then structured reporting using a system like the ACR lung RADS to guide the follow-up time for the smaller nodules, but then a multidisciplinary team capable of risk assessment and deciding when to test beyond just surveillance for growth. It's the most important thing in balance, once you get somebody in. If you might imagine a time that you never harmed anybody by over testing a benign nodule, and you knew right away when something was malignant and you treated it very quickly, then the rest of all the who should we screen, how do you balance, kind of goes away, right? This is the balance that we're really trying to strike. And the greater that balance tips towards benefit and harms in managing lung nodules, the more open you can be about your target population.
Yeah, completely agree. Julie and Peter, I think hit the head, nail on the head. This lung cancer screening is about managing pulmonary nodules that we went out and intentionally found, right? We've all had experience with incidental nodule programs, and there's a lot of overlap into doing this well, with some important differences. But I worked in two different hospitals. I have a VA health system that's not behind me, and I have the university health system, which you see over my shoulder here. Our VA has a really wonderful conference every week. Every single lung RADS 3 and 4 is reviewed, and some of those I find very interesting get upgraded and some get downgraded in that conference. And I would love to see the degree to which that percentage is consistent across programs. I have not yet been able to get us to review every lung RADS 3 and 4 for the larger volume of screens that we do here at the system behind me at the university hospital. But that's something that I'm very curious about, and how having 7 or 8 different heads in the room, 2 or 3 radiologists and 3 or 4 nodulologists, how does that make us better at getting people across the finish line?
Yeah, Doug, our group presented that maybe 5 years or so back at ATS, because we had the same structure with a nodule conference every week, and we review all of our positive lung cancer screening scans together. And I can't recall the exact results in this was data from several years back, but we more often narrowed the interval, got a short interval scan.
Yeah.
And so I'm not sure, we didn't have enough time, out to look at the ultimate outcomes, whether those scans would have made a clinical difference for those patients. But I think it's a really interesting question, because certainly in the cancer space, right, multi-D tumor boards have been shown to improve guideline concordant staging and care. There are some studies, interestingly, showing longer time to treatment initiation, but the treatment is more guideline concordant for cancer. So, so there's benefit there. I would imagine we can extrapolate that hopefully to our nodule conferences, but we don't know.
Yeah, the interval, I think that's a good point, Julie. The interval isn't from when you discovered the nodule to put a needle in it. That's important, but I think for rushing to do the biopsy, we're probably hurting more people than we help. The interval is discovery nodule to staging and treatment plan, and so that's the interval we're most concerned about.
Yeah, I think the other thing, just to throw out there, because we're hoping that these messages reach broadly, not just our big programs with ease of developing these multidisciplinary conferences, but there are ways now to reach out to larger centers and share your nodule cases. There are tumor boards at a distance and things like that. And I'd encourage any group that really wants to be screening locally but is concerned about their capacity for managing concerning lung nodules to try and partner with regional or statewide centers that might be able to help.
That actually dovetails very nicely into our final component that we'd like to discuss today. And there's a lot in this last component. In fact, Dr. Mazzone authored a often cited 2021 paper in CHEST about this very topic of proposed quality improvement measures for lung cancer screening. And in this particular article that we're discussing today, there are a number of different proposed quality metrics, including uptake, adherence, timeliness, benign biopsy and resection rates. And as pointed out, HEDIS measures for lung cancer screening officially do not currently exist. Although several societies, including the ACCP, have proposed these quality metrics. However, aside from the massive task of programs accurately both measuring and accurately and consistently measuring each of these different outcomes, one of the major points of controversy that has sparked many editorials, many different scientific symposia across many different conferences is what should constitute the minimum requirements for each metric that would signify, in this case, high quality lung cancer screening. For example, what should the ideal uptake and adherence rates be? We know that even in colorectal cancer and breast cancer, those rates are not 100%. They're in the 60 to 80% range. There's been several articles that have been published that have modeled that if everyone who is eligible in the United States actually does get screened and is adherent to subsequent follow-up, we actually do not currently have the number of low-dose CT scanners in the country to actually allow everyone who is eligible to get the care they need. And so I recognize that this is a little bit of an existential question, but I guess the questions that I have for all of you are, how should we, number one, specify what each of these metrics should be, what the actual value should be for each of these different quality metrics, and then what studies do we need to prove that point, or to help us understand what our targets should be? And for this question, I believe we are back to Dr. Mazzone.
I think it's a great question, and there's answers that might sound like they're dodging the question a little bit, but I think they are honest a little bit too. I think if you don't measure your quality, then you're not going to improve. You're not going to know. And so the starting point is to measure, and then what should you be targeting? Again, I know this isn't the right answer. Better. Next year, you should do better, no matter what it is, whether it's uptake or benign biopsy or time to diagnosis. You really should continue to improve. Ideally, these are shared nationally without names, whatever, so what standards are, and we see as a community that those standards continue to get better. In the quality measures paper that you reference, the experts who were part of that paper and were surveyed were asked to give a target percentage, and so things are included there. But maybe you're a brand new program and that's not quite what's right for you, but you want to measure and you want to get better. That was a bit of an experience. You don't think of these things as being so difficult to develop, really, but there is a science behind them. And so if you're thinking of your own, there are really three criteria when you're developing those. You want the measure to be valid, and by valid you mean, if I meet that, my outcomes are going to improve, are going to be better. Just doing it because it sounds like it should happen, but no, nothing else changes. So it should be valid, should be relevant, meaning if you're already there, you're already doing it, then why measure? Just maintain. And then, very importantly, where we fail a lot is it should be feasible. It may be a fabulous metric, but if you can't measure it, if you don't have the data systems in place, the people in place, maybe it's not the right one for you and your program at that time, or for sure it isn't. You need all three of those for a quality metric to actually help. And then you look at them, you measure, and you look every year, and you share, and you put tasks behind each of those on how can we improve, how can we do better. There's no one solution. You just keep chipping away at them.
I'll tackle the, uptake and adherence piece, and go out on a limb a little bit and say we should aim for 100%, right? We know that among all people diagnosed with lung cancer, only about half are eligible for lung cancer screening. So even if we screen 100%, of the patients who are eligible, we're still not going to be able to identify all the lung cancer cases early. Our data, our robust RCT data supporting lung cancer screening, right, and our modeling studies often build off of very, very high adherence rates and and the modeling studies, right, have to make assumptions about, high proportions of screen eligible people actually getting screened. And then we're seeing the mortality benefit. So I think we have to aspire to meet all of those thresholds. To your question about, or your comment about, capacity of radiology systems, I actually think our limitation will probably be the thoracic radiologists more so than just the physical scanners, right? We're already seeing that thoracic radiologists are in high demand and stretched very thin right across the country. So I think this is where, the leading edge of the field in terms of, using AI, using biomarkers, whether those are blood-based biomarkers or radiomic biomarkers or other ways to predict lung cancer risk and lung cancer diagnosis, can potentially help us. And it shouldn't hold us back from screening, as many people as possible within those eligibility criteria to worry about the constraints.
I just want to highlight with what Julie said, that we have to remember all of the eligibility criteria if we're saying 100%, right? You have to be well enough to benefit. So it's not just age and smoking history. You have to be well enough to benefit. You can't have had a CT scan in the last. We find about 15% of our screen population gets a diagnostic CT between our annual scans, symptom, ED, whatever it may be. So I agree with the very difficult but appropriate threshold Julie set, but we do have to remember that some within those age and smoking histories probably won't benefit and shouldn't be screened.
Yeah, the denominator is very, very hard to estimate.
I had an interesting discussion with a colleague, and actually, I've been working with some of the folks at Kaiser Permanente, Colorado, and we have a paper that's accepted in Cancer, hasn't been published yet, but basically we're looking at their centralized program within the integrated Kaiser Permanente system. And a colleague of mine, tangential to this, is in Canada, and they've actually run into the issue where they have had, in the case of Kaiser Permanente, actually a mistake, a glitch in the computer system that accidentally auto-ordered lung cancer screening for everyone in their system that was eligible based on just smoking and history and age. And very interestingly, they noticed that obviously there was an increase in the number of people getting uptake of initial screening, but there was a consequential decrease in adherence among the people who were already being screened. And so this is actually a real issue that some programs are already dealing with. Obviously, that's a kind of very specific case example, but in the case of Canada, some of the government sponsored and a little bit of a different healthcare system structure, there are programs in Canada, for example, that are actually at capacity already, and they are having to choose between people who have already been screened once, and should they come back for their next screen, or should we, open the valve and let new individuals who have not yet been screened, who are eligible, be screened because of this issue of resource allocation. And so I'm actually really, and we're in the midst of working on a project actually with the CISNET group to actually look at addressing some of these issues from a theoretical standpoint. But I'm really curious to hear folks' thoughts on if and when we get to that, if we are all so lucky to get to that point where we actually are having to do this, how should we think about prioritizing this potentially precious resource?
I would hope by then we have more simplified systems that identify net benefit. That is to say, perhaps life years gained or better adjudication of comorbidities, so that you could then say, your life expectancy is less than 10 years. Chest recently published a paper on what would be the minimum life expectancy one should have to expect to benefit from lung cancer. And it's on the order of 5 to 10 years, depending on your perspective. We aren't great at that, as we've talked about earlier. We're pretty good about on a population level, not very good about that on an individual level. And in this futuristic scenario you describe, hopefully we get better tools to identify people who have limited life expectancy and therefore limited benefit from detecting cancer at a very, very early stage.
I think it's a real issue that's not talked about too much, and I agree with Julie. In our own experience, we have a big group of chest trained radiologists, and they're strained already, and we're not near the uptake that we could be. If we doubled our program, they couldn't handle all the reads, let alone do we have enough scanners. So it's a real issue, and I hope that in seeing this develop, there's more radiologists and more scanners, but then technology becomes easier to apply. AI as a first reader might offload some of the radiologists' time. Those tools are close enough. Might molecular biomarkers or other types of tests minimize how many individuals go on to low-dose CT scans over time? That's all possible. But you asked a provocative question, so you wanted an answer. I think I hope we never have to get to making those decisions. But to the best of my understanding, most of the benefit ultimately comes from incidence cancers, not the prevalence cancers. And so if you really had to prioritize, you probably want that person to be coming back.
Yeah, speaking of the CISNET group, I think there was a paper earlier this year or last year in JAMA Network Open looking at biannual screening and age adaptive screening, which I think are really interesting questions to ask. Obviously we can't have an RCT for every single different type of screening strategy for every high-risk group. So, we'll have to have, I think, a better understanding in the future of how we can use modeling studies, real-world studies, and other types of data to best inform screening practices going forward. But I agree, coming back to the shared decision making, right, that with where Doug pointed out that bringing, up front to the patient at the first time they're joining a screening program or getting their first scan, this is a process. We're here to support you. It's important to come back year after year, and I think that's an important concept to introduce early on.
Well, I just wanted to thank all of our expert panelists for spending an hour of their time with us today. This has been a phenomenal discussion. I think we covered a lot of ground in a very short amount of time, and certainly we could all talk for hours longer, as many folks have mentioned today, about some of these topics. But I just wanted to thank you all again for your time, and I know I learned a lot from hearing your insights, and I'm confident that our participants also learned a lot. And as a reminder, this webinar has been recorded and will be uploaded onto our official ATS Thoracic Oncology Assembly website, and then also our YouTube channel. So this will be available for future viewing. So thank you all for joining us again today. I hope you have a wonderful rest of the day.